Good evening. My name is Renee Sanchez, and I'm a founding member and a chair of the Nursing Administration Alumni Advisory Council, and delighted to welcome you all here tonight for this a wonderful event. A few months ago, nurse executives and CNOs from the NYU Nursing Alumni Board suggested to our council to host a program that focused on the opportunities and challenges nurse managers are facing today during this critical time in our nursing profession. Our council felt this would be an incredible program detailing the day-to-day obstacles that nurse managers face in their roles as they lead and support their teams to provide safe patient care. Tonight's panel will address some of the most pressing issues in a nurse manager's position, such as providing safe care to patients, motivating and engaging others, retention of current nursing workforce, and supporting new nurses as they transition into nursing practice, as well as balancing wellness and more. Nurse managers make decisions that positively influence how hospitals and clinical organizations perform. The nurse manager role is the most critical role in any organization. We hope this panel will be inspiring and helpful for your practice. I will now introduce the panelists. We have Megan Clampett. She received her master's in nursing administration from NYU Myers in 2018. She is a nurse manager at Mount Sinai Hospital. We have Marissa DeFilippis. She received a BS in nursing in 2013 and a master's in nursing administration from 2020 from NYU Myers. She is a nurse manager at NYU Langone Orthopedic Hospital. Natan Santa Cruz received his BS from NYU Myers in 2017. He is a patient care director at New York Presbyterian Weill Cornell. We have Erin Smith. She received a BA from Marist College and a BSN from Grand Canyon University. She is a nurse manager at Lenox Hill Hospital. Alexa Carroll will be our moderator for tonight's event. She received her master's in nursing administration in 2020 from NYU Myers as an active member of the Nursing Administration Alumni Council. She is currently a nurse manager at NYU Langone Health. If you have any questions during the panel, please type them in the Q&A or the chat, and we'll get to them as many as we can by the end of the discussion. I feel like this is going to be a great discussion. Now I'll turn the program over to our moderator, Alexa Carroll.
Thanks, Renee. Welcome, everyone. Thank you to our panelists for taking the time out of their evening to be a part of this program tonight. I hope everyone is comfortable and ready to talk about the relevant topics with our nurse managers. We will jump right into the first question, which each panelist will answer. It is often said that the nurse manager role is the most challenging leadership position. What keeps you fulfilled day to day and long term? We'll start with Natan.
Thanks, Alexa, and thank you guys for having me here. It's an honor to be here with everybody. I would say that what keeps me fulfilled probably is the people. So that's probably the people that I take care of on a daily basis, the patients that we have and who give me a chance to take care of them during their most vulnerable time, and also the people that I work with who have become like family. Some of the things that we've been through together, the kind of things that will tie us together in ways that I couldn't even explain to my own wife. She just wouldn't understand. That keeps me going both day to day and long term.
Great, thanks, Natan. Marissa?
Thank you so much for having me. I think this is going to be a great night. What keeps me fulfilled day to day and long term is seeing the nurses that I work with own their practice and have their voice heard in different avenues. Watching them realize that they have invaluable input in almost every aspect of a patient's experience really keeps me going. I had a patient recently that remembered me and other staff from being on our unit several years prior, and hearing her speak very specifically of experiences she had with individual people, even 3 or 4 years later, made me understand the impact that we can have in crossing paths with the person in just one day.
Great, thanks, Marissa. Erin?
Thank you so much for having me. My take on this would be after in a post-COVID world, 2 weeks into the pandemic in 2020, my behavioral health unit, which is a very niche type of unit, was closed. And we opened to take care of COVID patients and eventually turned into a COVID ICU. So after a year and a half of being back in my home with my patient population, My staff and I have been very excited and honestly living in the day to take care of a very challenging but very vulnerable patient population that we were unable to care for a very long time. So that motivates me to go back into doing what we love to do.
Thanks, Erin. And last but not least, Megan.
Hi, everybody. I'm Megan Clampett, and I'm the nurse manager in the neonatal ICU at Mount Sinai. And what keeps me going is seeing the nurses at the bedside in the NICU practice to their full scope, seeing how I can support them to be autonomous, seeing how they can not only be a part of the team, but lead the team in many ways, as not only the patient's advocate, but as a gatekeeper, as the expert, as the aunt to the baby. The NICU nurse really just plays an immensely vital role in the patient care, and to see the families come back, send us cards in the holidays, and come back and see the children come at age 2, age 3, age 4, and so on, and to see that they used to be a 24-week premature baby, and now they are just a thriving 3-year-old, keeps me going.
Great. Thanks so much, Megan. And thank you to all of the panelists for answering this question. These are great examples. You each had your own unique take on it, but I think they all really, together back to the teams that you work with every day. And obviously, most importantly, the patients and the care that's provided to them. So with that being said, we'll move into the next question, which has 4 parts to it. So we'll take each part one by one and let the panelists answer them separately. So the second question is, share some of the day-to-day challenges for nurse managers and solutions that have been put into place regarding the following 4 topics. We'll start with quality first. And so Natan, can you start us off and speak to us about some of the day-to-day challenges surrounding quality and solutions that have been put into place?
Sure. Yeah. So, I mean, this is a challenging question. So I would say, having to be creative when it comes to resource shortages, certainly staffing is top of mind lately. Having to maintain our really high standards, regardless of how many staff we have, has been a constant point of focus. Knowing how to read the temperature of the room, when to focus on certain things, like, for example, Joint Commission, how to talk about it when people are tired and burned out, always maintaining a positive attitude, even when I'm personally not feeling it inside. Some interventions we implemented. Most important for me personally, I think, is just the positivity piece. I'm not talking about toxic positivity. One time the staff told me, stop trying to find solutions all the time. Just tell us when it's all effed up. So I took that to heart and I just try to listen. Sometimes I will offer solutions if there are any easy wins, but otherwise I just try to listen and always close the loop. Closing the loop goes a long way. Big or small, staff really appreciate that every escalation is taken seriously and followed up on. Some additional interventions we've implemented are a mentorship program, since we're, almost 50% staff that started within the past couple of years. I'll talk a little bit more about that a little bit later on. Also, more frequent check-ins for newer staff, focusing resources on high impact areas, like, for example, lead arounds on admission and discharge. When we are short an aide, for example, having the aides focus their attention on patients with central lines. We're a hematology oncology unit, so a lot of our patients have central lines. And then lastly, and probably most importantly, is just transparency to the staff, from things like finance and how ADC affects our staffing to things like HCAHPS. Who gets a survey? When do they get it? What are they reading? And what are the ways we can try to leverage the best possible results that'll be indicative of the quality of care that we know we give every day? I can't say that I've figured out any kind of silver bullet or magic strategy, but just learn to expect the unexpected and be adaptable.
Great, thanks, Natan. I think those are all really great points and things that nurse managers face every day, right? And have to navigate either, communication, transparency, finding a solution or just, escalating in order to get the answers and the supplies, even if that's what we need to take care of patients safely. Okay, so the next part of this question is speaking on retention of current and experienced nurses, along with supporting new grads transitioning into practice. I have Natan, if you want to start first, since you kind of spoke a little bit about it in your previous, and then we'll move on to Marissa and Megan.
Sure, happy to speak about this. It's something I'm really passionate about. So my retention strategy really starts with recruitment. So being selective and patient until a candidate who is the right fit comes along is key for me. One RN, for example, recently I waited 5 months for him to graduate. Ironically, he was an NYU Myers graduate. I identified him at an NYU Men in Nursing event, and I immediately reached out to him, and then I had to wait 5 months for him to graduate, pass the NCLEX, which thankfully he passed the first time before he could start his orientation. After recruitment, the focus is on frequent check-ins. I was told recently that if you can retain nurses for the first couple of years, then your chance of having them for 5 years goes up by almost to like 90%. So I focus a lot on the newer nurses. We have a really robust mentorship program, which I had mentioned recently prior in the previous question, for new nurses where they're paired up with more senior nurses who maybe fit their personality style. And they aren't told what to talk about or when, but just to meet outside of work and just to do additional text check-ins, just to make sure they're okay. Then when I send them to night shifts, I want to make sure that that's at the right time. It used to always be at the 6-month mark when they pass their probationary period, we'd send them to nights where there's a little bit less support. But for everyone now, it's more of an individualized decision, waiting until they're comfortable and then sending them when they have a really good command of their individual skills. And then making sure to continue the constant support until they find a schedule that works for them. I always emphasize the importance of putting their health and safety first, which means prioritizing their self-care, making sure that they take their breaks and taking advantage of their days off to rest and refresh. Around the 1-year mark, I like to start focusing on opportunities to get involved. Okay, so you've seen the big picture, you're not task-oriented anymore, you see that it's not perfect. Plenty of things that can be improved upon. So what impact do you want to have? What fingerprint do you want to leave on your time at the bedside? I also like to tell people that I'm not trying to keep you here forever. I recognize that nursing is a journey, and some people may want to be bedside forever, and others are using it as a stepping stone until their next opportunity. I always like to tell them my role is just to help them get to every step along the way, even if it's not here. So I ask, where do you see yourself in 5 years, and how can we take steps to get there?
Great. That was a very detailed explanation with so many things. Thank you so much. Marissa.
Yeah, I think I can piggyback on some of the things that Natan spoke about. Starting with recruitment, I think we've all felt the pressure in the last couple of years to just hire people to fill positions, but I find it so valuable to hire people that, you feel will be a good part of your team. And there is a fine balance because we have the staffing challenges and you want those resources on the unit, but they might not stay if they're not the right fit for your team. And part of that is having the staff nurses involved in the interview process, I find is really invaluable. I want them to want that person on their team as well. It's not just my decision to an extent, but it needs to be someone that they feel like will help elevate them and elevate the practice that they're doing every day. And then once we have wonderful nurses hired to the unit, I think I've changed, and that could be just as I've gotten more experience as a manager. But I used to feel that new nurses need to get acclimated to the unit, whether they have experience or they're new graduates before they become involved in hospital activities, the nursing shared governance councils. But I've changed that strategy a little bit and capitalized on their energy and their excitement to be somewhere new and to learn, and have them joining councils or partnering with a more experienced nurse on a quality improvement project right from the beginning. so that they feel engaged right away. So that's something that I've been focusing on as I've hired new staff lately. And I've been a part of some really interesting work groups to change our care models and how we're supporting new graduate nurses. We're about to be part of a pilot for a nurse clinical advisor, where a new graduate would have an experienced nurse as somewhat like a mentor over their first 2 years of practice. And we've also looked at expanding our nurse residency program to 2 years versus 1 year to be more of like a fellowship program. And I think that'll be really exciting. The nurse residency program provides a lot of support. It's an opportunity for new graduates to connect with others, not only on their unit, but also on other units, and create a support system for themselves within the hospital. And I think having that extend for another year will help support them along their way.
Yeah, I agree, Marissa. Thanks for sharing. And I liked your point too about having staff input on hires as well. And I think that's been, during the COVID pandemic, the past 2 to 3 years has been challenging because many of the interviews have been virtual, which doesn't give the candidate an opportunity to come to the unit and the staff to see and meet them. So hopefully as we continue to move forward, that will come back. Okay, and Megan?
Hi, thank you. So to go in order, recruitment, right? So for recruitment, I totally agree with Natan in that I am selective. I do have vacancies, but that is not my goal to be 0 vacancies at all times, because it doesn't mean anything if they leave in 6 months, 7 months, 8 months. Not only is that a big cost to the hospital, but more importantly, it is a drain on the preceptors, which are my life-saving, their goal, their everything is the preceptors. I don't want to have them anymore tired or frustrated or doubting themselves if people leave early. So to me, I am okay with having vacancies if that means the people will possibly stay longer. Another part of my interview process is being very transparent. There is nothing that I won't answer, that I will dance around. I am extremely transparent about this unit and I want them to know all of the positives and all of the things that we're working on. And I do think that my, resume speaks for itself regarding that. I was a clinical nurse on this unit. I became an A&M, and then I was a nurse manager. When they ask me questions about myself, I share that. And I tell them, that keeps me here. There's many things that keep me here, but these are the things we're working on. And I have been told that helps. Sometimes they, might decline my offer to join my unit, and that's okay with me, because that maybe means they would have stepped away in 6 months, 7 months, or a year. And then moving on, when they join the team, I always ensure that they join in cohorts. I don't have anyone start alone. Now, maybe that's one of the things that is good about a big unit, is that you can do that. And when you have several vacancies, you can do that. If you just have one vacancy, that person will start by themselves. But I've learned that it's really beneficial for them to have coworkers and colleagues and friends immediately who are exactly in the same place as them, starting the same exact day as them. And they get each other's phone numbers on day one. And they are that support person, because it's not easy to be in any unit as a new grad in this climate, especially an intensive care unit, especially with babies. And it's very unnatural to see babies so sick, with so many lines and drains and things of that nature. So to really build a support system for them immediately. Then moving forward is to really be strategic about who their preceptor is, to really think about each person's background and their personality as best as you can, and ensure, for me, that 2 preceptors to 1 orientee on the day shift, and then 2 preceptors to 1 orientee on the night shift, to make sure that they see that it's not all black and white. People do things a little bit differently, and that's okay. And when you get to the end, you'll put it all together. I just don't want them to get too confused if they have a million preceptors. So that's kind of a beginning strategy. And then, moving on, once they've passed orientation, in order to retain them, definitely I agree with the committees and the champions and the education. I used to say that after 1 year, you can take the ECMO class, because I thought the ECMO class would be a high level for a new person who's here 6 months, let's say. I changed that strategy. Why stifle anyone's interest? If you want to take the class, you can take the class. Anyone, it's open. I think that has helped. And then also a little bit of a different way that I retain staff is that I ensure that I am fair. And I think that it seems maybe like a simple thing to be fair, but it's not. It's hard to do that every single day, and to make sure that you're fair with patients and nurses, and that every patient and every family is treated equally, but also that I am taking into consideration their situation. Nurses, same thing. You don't want anyone to feel like a nurse manager has favorites or anything like that. And that I'm consistent and that I'm a stable person. It's oftentimes you'll see a nurse manager stay for 1 year, maybe 2 years. And you'll see nurses say, oh yeah, I've had X amount of nurse managers in this unit, your number, blank. So I knew going into this role that I wanted to be that constant for them. I wanted them to feel like they can trust me, and that I will follow through on initiatives, and I will follow through with them, and I'm here for them. So just to be that person who is reassuring them that I'm here, I'm not going anywhere, and that I'm also someone who, again, not toxic positivity that was mentioned earlier, but that recognizes that you're always on stage, and that shows an example of professionalism, and making sure that they can hopefully, in a way, look up to me in that way, and show them that I can lead them and that they can feel safe to do what I ask. And hopefully that retains people.
Great, thanks so much, Megan. And you kind of touched on one of the questions we'll get to later about retention of nurse managers. But these are all really great strategies, and bring up day-to-day challenges about staffing, recruitment, supporting new grads at the bedside. And I think a lot of the 4 of you have similar strategies and techniques that you use, and I think these are really great, especially as we continue to fill our vacancies and look to get the right people staffed in the units. Okay, so the next part of this question also ties into retention. But Aaron and Megan, if you can speak on wellness for leaders, as well as staff wellness.
I'm happy to open that up. So it's been so amazing to hear the pearls of wisdom that you guys have shared with us. I'm thinking, Natan, when you talked about mentorship, when I became a nurse manager, if I knew some of the things that I know now, wellness, I believe, needs to be so proactive. And I remember when I was a new nurse manager that I felt like I needed to do everything for everyone. And I needed to solve everyone's problems, and I was available 24/7. And, you know, I gained a lot of trust of my staff because of that. And that was, you know, it had its pluses, but it also caused a lot of burnout. And it caused it, you know, that's very, very hard to keep up. So as I've, you know, continued on this journey as a nurse manager, and, you know, I mentioned before, my unit has been closed and reopened, and I took over surge units. I think that scheduling proactive time to be away from the hospital, to be away from the staff. You know, 2 years ago was the first time that I actually shut my phone off and didn't look at it while I was on vacation. And the first 48 hours were so unbelievably anxiety provoking. But as you know, I look back on that, it's really necessary. It's a really important thing for you to be able to take a step back and be well for yourself so that you can help others get well. As far as staff, you know, wellness for staff is something that at Lenox Hill we've been concentrating on really significantly. I'm actually a founding member of something called the Team Lavender, which is something that once upon a time was called Code Lavender, and it was code caring for the caregiver. So when we, you know, we spoke of quality this evening, when we talk about debriefing things when they happen clinically so that we can make them, you know, better outcomes next time. When there's a, you know, we are a very emotional, you know, place. Hospitals are a very emotional place to work. We have very emotional jobs. And when things happen, it's important to be able to take a step back and debrief those and let people hold space for their feelings. So we have Team Lavenders, and we've decided to do Team Lavenders proactively to kind of talk about staffing challenges and talk about, you know, just what are you guys feeling? How are things going? We also do something called Wellness Wednesdays, where within the last 6 months or so, we have had pop-up wellness units. So we have virtual reality goggles, and literally for 5 minutes, a nurse can go into a break room, or they can go sit in a massage chair. Or not, it's not a massage chair, it's like a massage back thing. But those small moments of being able to take the step away have proven to be exponentially important in letting staff know that we care about their wellness, but also having them be able to sustain the very difficult work that we do every day.
Yeah, that's great. And I know a lot of organizations have instituted the lavender teams and other wellness, you know, strategies, especially post-COVID. And I think that's only going to grow as time goes on, which is, I think, a positive change. Megan, do you have anything you want to add?
Sure. Yes. People ask me that a lot. You're still here. I say, I'm still here. And you know, I think one of the positives of starting a nurse manager job on day one of returning from maternity leave was that you need to have some sort of barriers in place. You need to set a time at when you're leaving. You need to go pick up your 4-month-old. You know, that is just a need. You have to do that. You can't just slip into something that is unhealthy and be there 14 hours a day. So for me, you know, prior to that, I was an interim nurse manager, you know, before kids, and I did an A&M and I did other things, but truly having the role, that was when I started. So I built these mechanisms where you know, okay, I'm leaving at this time. Now, was it an 8-hour day? No, it was longer than an 8-hour day, but it wasn't a 12-hour day, 5 days a week. And it was like, okay, at this time I need to go and I need to leave this on my desk. And before that, as an A&M, I never understood it. I never understood how the nurse manager could leave this pile of papers on the desk. And then you realize immediately when you're the nurse manager that you absolutely need to move something over to tomorrow. You'll never finish your work and clock out. That just is not the case. So building that as part of just my day-to-day is I leave at this time. And if something happens, of course I need to make changes, but that's if something urgent happens, not if someone is knocking on my door about a schedule switch or needs time to vent. That's not the time, because I need to go. And I think I've always also thought about this as a career for me, not necessarily a stepping stone, and thinking about my life and thinking about 30 years and thinking about this is a marathon, not a sprint, and I'm going to be healthy and not run a million miles an hour and then have exhaustion. So that to me was maybe a good time in my life when I started that, and am able to continue that. And yes, of course, I'm on the phone on the weekends and stuff like that, but I know I don't need to answer every single thing immediately. Some things I can respond on Monday morning, and you get better at that as the months and the years go on.
Yeah, that's also true, Megan. And I think that's something, everyone on this panel and those who are attendees can relate to. It's very hard, right? When you just like one more thing, and I can do one more thing, but I think setting the boundaries is, really key. And, not like you said, there's some things that are urgent that you have to wait for and stay. And there's other things that, you set your time and this is when you're going, and the rest can be handled tomorrow. Okay, great. And we've made it to the last part of this question, believe it or not. But this will focus on the safety of staff. And we know there is recent literature about aggressive patients. So Erin, as we know, your background is specific to behavioral health. So if you would talk a little bit about this topic and ways in which you ensure your staff safety while providing bedside care.
Absolutely. I actually had a lot of thought of this panel discussion today because ironically, one of our physicians was assaulted this morning. I was in my office on a webinar and had to jump off because unfortunately, this is a very real part of our day-to-day. And thank God he was okay. I personally took him to the emergency room. He was triaged and we sent him home. But this is something that's very, very real for us. It's also real for every other unit in the hospital. In the NICU, I know that there can very clearly be upset parents, right? And that's going to be a very real thing. That is something to deal with. My behavioral health patient population is especially challenging. And again, I spoke of proactivity with the wellness, but it's something that we are also very, very proactive about with safety. So all of my staff, every single person that walks onto the unit and has any role, including our housekeeper, takes a class called PMCS, or Preventing and Managing Crisis Situations. It is a mandatory annual class. I'm actually blessed that my assistant nurse manager is an Office of Mental Health trained trainer. So we offer this class at least once a month. We are in the JCAHO window, so there have been times when we have had 4 in a month, much more recently, but it's also as needed, right? Because these strategies for de-escalating a patient are a real thing that keep people from getting hurt. It's an occupational hazard to come onto a psychiatric unit where there are behaviorally dysregulated patients. But we try to give people the tools. We have also in the past year or so, opened up this class to the entirety of the hospital. So it is an obligatory class for psychiatric staff as well as emergency room staff. We have all of our security guards, regardless of where they are posted throughout the hospital, also take this de-escalation class. But we have opened it up to any nurse, any PCA, any tech that works on any unit in the hospital, to give them the opportunity to kind of learn these skills and try to know the triggers and the warning signs of a patient who is escalating and how we can try to get ahead of those. We talk about a patient who is in pain, right? That's something that everyone assesses and then reassesses pretty regularly. And if someone's in pain, we're going to give them medication for pain. If someone's nauseous, we're going to make that assessment and then we're going to give them medication to combat the nausea. When a patient is agitated, it's necessary to give them medicine. It's not a punishment. it's helping them. It's helping the patient, because acting in that manner is often incredibly uncomfortable. They're not acting that way because they're having a great day. And sometimes it's volitional. And we do have patients on our unit and throughout the hospital that, have behavioral issues. And there also are patients that are really suffering and are in need of some help. And that's how we help them. We huddle very, very regularly on my unit. It's a part of the de-escalation course, but several points throughout the day. So in the morning, the nurses will, the entirety of the interdisciplinary team does after rounds every day. We do an additional afternoon huddle. And then in the evening time, my assistant will do another one with the night staff when they are coming in for situational awareness, right? We're going to let everyone know who the patients we're concerned about escalating. And we're going to be as proactive as possible to do the right thing for the patients, but also to make sure that we're keeping our patients and our staff safe. Because if the staff don't feel safe, it's harder to come back and do that every day, right? And even if we feel that they are safe, there are times when people will be assaulted, like today. So it's really important to have that awareness and then debriefing any event that happens and looking in real time about what happened and could we have done something differently. Unfortunately, a lot of times there aren't, but I think that if there was 1 out of a million times that we could have done something differently and it kept someone from getting hurt, then that would be worth it.
Yeah, great, Erin, thank you. And I can imagine, it's like you said, that you never know when something like that's going to happen, like this morning, and just trying to put things into place and debriefing to see if you can do anything differently for the next time. Erin or any of the other panelists, can you speak a little bit about not only necessarily physical aggression, but emotional situations or traumatic events that cause staff emotional distress, and how maybe Erin or anyone else handles that on their units?
I can actually, I'm happy to jump back in. I can think of a day very specifically that Renee and I will be forever bonded over. As I mentioned, my unit was closed. Renee's unit was closed when we worked together as well. And emotional safety is so incredibly important. I think during COVID, everyone felt very emotionally unsafe. It was petrifying to walk into a building that was practically on fire and not knowing whether we were safe or not, literally safe. But I can remember being verbally attacked by a family after the death of, very unfortunate death of a patient. And I think that ties back into some of the wellness stuff that we talked about, because that does happen, right? Like, I understand in hindsight that woman was not attacking me, telling me I killed her mother because she believed I actually killed her mother. But her emotional pain was so horrible that she needed to project that out. But I can remember that, honestly, I actually was talking about that today as well in the debrief, and trying to tie in emotional and physical safety and aggression. And honestly, in my almost 12 years as a nurse, that emotional attack was probably, I would say, the top 5 worst days of my nursing career. And I've been physically assaulted on more than one occasion. So it's ironic to think that the emotional attack was that much more difficult. But I think it's really important for us to be able to step back and say, it's okay to not be okay. It's never okay to be verbally or physically assaulted by anyone. And those boundaries are really important, but for us to be able to recognize that it's, very much not only a physical problem. I don't know if anyone has anything else to add.
Yes, actually, last month, I'm very fortunate to not have been physically assaulted in my career, but last month, one of the mothers did call and threaten the unit based on a rule that I had to implement, and I had to tell her that we couldn't have the room set up as she wanted around the holidays. and she called the unit and told the nurse that she was going to be there in 2 hours and to call the police because something bad was going to happen to the unit. And her background, like her history at our hospital was, she very clearly was not happy with the care. Several times pointed that out. So people were genuinely nervous that she was going to bring in a weapon, or she was going to take some action, and it was happening today. So my role was to ensure the staff that security is going to be present 24/7. If she arrives frustrated or upset visibly at all, she will not be permitted in this unit. There is no room at all for any kind of outburst or any kind of raising voices or anything at all. I promise, call me immediately. And to really ensure that that security officer wasn't just present for one shift, but has been present now for a month at the bedside, to really make sure that this situation is, at bay, because a lot of families also are nervous. Their own babies are there. And the nurses were very nervous. So just to reinforce that, I'm here for them as the nurses. They are my priority just as much as the patients. And we are not going to just, let this one go. I think nurses are concerned sometimes that their safety is second, and that it absolutely cannot be the case.
Yeah, thank you to both Erin and Megan. Both stories gave me chills, and Megan, I had a similar situation when I worked in peds as well. So I understand, you see it from both sides as a clinician and as a manager, and these are, like you said, urgent things that need to be swiftly addressed. And how do we make sure that staff feel safe along with the other patients in the unit, right? These patients aren't solely by themselves. So it's ensuring safety on a lot of aspects. And I think, security, like you said, Megan, plays a huge part too, because they're our ally in a lot of ways in these situations. Okay, great. So that was a lot of questions, but of day-to-day challenges and solutions. But I think everyone, gave all of their answers, and thank you to all the panelists for contributing and your parts. So moving on to the next question, Marissa and Natan, if you would like to speak on your role in a leader, how do you motivate and engage yourself as well as your teams?
I can start.
Sure.
So I found over the years that being involved in my own professional growth keeps me engaged in my day-to-day work. When I was in school for my master's, I felt like I was at an all-time high. I was just so excited to learn all the different layers that the role of a manager. I was already practicing as a manager, but I felt like I was focused on more of the task-based things that come with the role. And then once I went to school, I really could see how complex the role was, and having the opportunity to do my clinicals with an amazing nurse leader, and seeing how positively influential you can be at any level really kept me excited about the potential of moving forward in my nursing career as a nurse leader. And then once I finished school, I dove into professional nursing groups, like New York Organization for Nurse Leaders, becoming a part of the Alumni Council, participating in events like this, where I just get to sit and hear from other nurse leaders and learn from them, and their experiences really helps keep me motivated to do what I do every single day and continue learning. And I take that back to my workplace and try and bring that energy back to my team. And a lot of that is focusing on, and I think Natan touched on this earlier, but understanding the professional goals of each of the people I work with and trying to individualize how I can get them to where they need to be, because I also understand they're not going to all stay on my unit forever. But I find the greatest joy in seeing people realize their dreams or their potential when they participate in a panel. I had one of our new graduate nurses participate in an ethics panel this morning about a patient that was on hospice, and it's not something we deal with every day. And to hear her be able to share her experience, the emotions she went through, and her recognize that maybe that is a path that she wants to take her nursing career from that experience. And then now I know ways to help get her there, is something that keeps me motivated, and I hope motivates my team too.
Yeah, to piggyback off of that a little bit. I mean, I like to I engage myself by, you know, engaging my team. It's very much a vicarious process. But the way that I engage the team is, you know, just by trying to be visible. So I try to come in as early as humanly possible, well before the sun rises, and I try to check in with every single person, even those that don't report directly to me, whether it's environmental services or porter, knowing everybody's name, the dining host. Also always trying to lead by example. I never ask anyone to do anything that I'm not willing to do myself, and I'll show them that. I'll go in, I'll clean patients, I'll do whatever it takes. I maintain an open door policy as well. Literally, my door is literally always unlocked, so they can always come in and use the computer if they need to for Zoom or for anything else. I keep their files locked, but everything else is open to them. I don't wear a white lab coat, not necessarily because I have a problem with it. I just think it, you know, I don't need the pockets, so whatever, I can just, you know, get myself dirty just like everybody else. I treat myself as an equal. I believe very strongly in autonomy. And this really starts from the top. I credit my director a lot, Herman, who is really big on this and who inculcates this in all of us on his service line. I like to tell the staff that my job isn't to tell them how to do their job, it's just to provide the resources so that they could be freed up to do what they do best. I believe that when you encourage people to be autonomous and back up their decisions, you can see them really shine and do some amazing things. We have a daily huddle in the morning, and I try to use that platform to shout out people who exemplify making these kinds of incredible autonomous decisions that go way above and beyond in impacting our patients' care. Recently, we had a new nurse who started just a few months ago. She was caring for a patient who had gotten bad news. He was supposed to transfer that day to bone marrow transplant for life-saving treatment for his already twice relapsed leukemia. But very dramatically, he was told at the last minute that it was canceled. He had relapsed, and he was very crushed, totally devastated. And then worst of all was that he was told he'd have to wait a long holiday weekend since it was Friday, and that he wouldn't get word on what his next steps would be until Monday. So his nurse, whose name is Katie, she knew that this patient was in a really bad headspace. She also knew that he really loved Legos. And he would buy these huge expensive Legos that would take weeks to build just to keep his mind occupied. But at the time, he didn't have any to build. He had already built them. He had two that were being shipped, but he didn't have anything that he was going to be able to do for the long holiday weekend until he could find out what his next steps would be. So she dropped everything on a day where staffing was not ideal. She found coverage for other patients. Then she power walked 3 miles round trip in the cold rain to the Lego store just to get him a Lego that he really wanted. I'm still often moved to tears and thinking about that and what it meant to him, but it's that kind of autonomy that I strive for all the staff that I'm responsible for to feel like they have the ability to make.
Thank you both. And yeah, like you said, Natan, those are the things that patients remember, and the gestures, right, that are so impactful. And the reason that we all probably went into this profession, whether it be as a clinician or a manager. So that, thank you for sharing that story. Okay, so as we know, engagement at the staff level and at the leader level is so critically important. So thank you for giving us your insight. And we know there has been turnover and vacancies within the nurse manager role across the country. So Erin and Megan, looking towards the future, do you have thoughts or ideas on how to attract and retain nurse managers?
I'm happy to speak to that. I think that given a lot of recent events, right, in our field, we have to start thinking outside of the box. I think that it's very evident by listening to the really inspirational, stories and experiences of the other panelists. And I am very grateful to have have worked with and continue to work with an amazing group of nurse leaders. But we would be remiss to not say how difficult this role is. We have the pressure from above, we have pressure from below, and as much as I'd like, I have a fantastic relationship with my director. She's literally coming to my wedding. I have a very, very close relationship with my staff as well. But I'm never going to not upset either, right? Because it's not possible to meet everyone's goals all of the time. So I think to attract and then retain excellent nurse managers, we have to think outside the box. I think that salary is something that is important, right? I think that I'm very grateful to see that nurses are fighting for and getting competitive salaries. But I think that the compensation for the nurse leaders with 24/7 responsibility has to reflect that, right? I think that when we look to see staff making as much or more than, in some instances, some of the nurse leaders in the building, in our case, that's frustrating, right? And I know that there are other talks of, at Lenox Hill, we have a very robust nurse manager council as part of our shared governance. And there are a lot of ideas that are thrown out. So flexible work weeks, flexible hours, potentially a work from home day. I think that thinking outside the box as to how we can get everything that we can do and need to do, but also tying in that wellness and that emotional safety and being able to hold space for ourselves, I think is key in being able to move forward.
Erin, you read my mind. So those of you who picked up on it, I work at Mount Sinai Hospital, and we had a strike last week, and it is incredibly draining on nurse leaders, especially nurse managers, during a situation like that. Something that many people will never be in, hope they never are in. Many nurse leaders never had that experience, even in 40 years. So seeing that, it really shows me how much I can do, how much my colleagues can do and rise to the occasion. But one of the topics is salary. That was one of the topics that NYSNA, was requesting is, a raise over 3 years, and doing the math, it does go above many of our salaries, and their benefits are much cheaper than those of us who are non-union. So that is something that absolutely has to change, or there'll be no retention for nurse managers. And then, but moving on, besides the salary, something that Mount Sinai Health System implemented a couple of months ago was a 4-day nurse manager work week. And that is really very helpful for me, and for many. The truth is, many health systems, I don't know any nurse manager who works 7.5 hours. I don't know one person who does that in any health system. And that it adds up when you're 5 days a week and you're doing 12-hour days, 5 days a week, and you're 24/7 accountability. So to have the health system get behind this, and support a 4-day work week is really just amazing. I never thought it would happen, and I'm in it. So that's just great. Another part of how to retain nurse managers would be to try to move away from the term 24/7 accountability. We know this, but it is not sustainable. It's not sustainable to be attached to your phone, around your neck, 24/7 and expect you to pick up the phone. There are times when you are at your own wedding. There are times when you are at your parents' funeral. There are times when you have a child with COVID. And there are times that these are serious, like you can't always be there. You're in the shower, you are going away for like 3 days. It's not going out of the country, but we have to have some kind of ability to sort of break away. Yes, I'll check my phone, but not every 5 minutes. I don't see a way to be 24/7 for 30 years. Personally, I don't see a way to do that without having a crazy busy work life and no home life at all. So I would really, that's important for our leaders to agree with, because it's for them too, for directors and anyone above the nurse manager role. That I don't see how anyone can sustain like that. But last but not least, what is so critical to retaining nurse managers are assistant nurse managers. They are everything to nurse managers. The only way you ever break away is to have an assistant nurse manager, and maybe that person just doesn't cover your unit, but maybe covers 2 or 3 units. And that is someone you can feel like you can hand off some work to, maybe not everything, but something. That is so important. And to have an organization that supports them too, because I want them to stay too. So that to me is everything. I will do anything for the assistant nurse managers that work for me. I was in that role, and I want to support them and have them turn their phones off and feel fine to do that, because it's okay. I got it. It's okay. You disconnect. And that is so important to me, to make their job also to be attractive, to have perks and to have benefits and have a flexible schedule and other opportunities there, and a competitive salary too. I think that's all my pearls of that.
Thank you to both of you. And, as we know, this is such a critical leadership role. So I think, a lot of these tie back into wellness too, as well, but important to think about as we, look to fill nurse manager vacancies and attract new leaders into roles, and how we can successfully do that, and also retain that, people are staying in their role, like you, Megan, how you said, this is your career, and that may not be for everyone, but some people may, want to stay and have that as their 30-year plan. And that's something we should look to obtain. Okay, so our last question, which again, all of our panelists will answer, is what pearls of wisdom do you each have for emerging nurse leaders coming into the profession? We'll start with Natan.
Thanks, Alexa. I'll just keep it brief, I guess, just looking at the time. So I just say a couple things. So first of all, never lose sight of what really matters. It's not HCAHPS, it's the actual patient experience and their family as well. It's not your quality metrics, it's the actual quality of care. And then the other thing I would say is never say no to an opportunity. Leadership isn't something that requires a formal role. You just kind of grow into it, whether it's in your job description or not. Own that, find what you're passionate about, forget about your ambitions and your goals, just focus on being. Opportunities will present themselves, just be ready to grab it and see where it takes you when the time comes. I think I've now had 4 different roles here at Weill Cornell, but I only applied for one of them, which was the nurse companion role that my professor at NYU, Fidel, helped me get. The rest of them just kind of came as opportunities that presented themselves as a result of just being present at the right place at the right time.
Great, thanks, Marissa.
A pearl of wisdom I would share is, if your organization has a mentorship program or an opportunity, take advantage of that. I've found that identifying leaders in my organization, outside of my organization that I connect with, their leadership style, the values that they share with their teams has really helped me grow and learn, and has been a positive for me in my journey as a nurse leader. So that I would suggest that take advantage of any mentorship opportunity that you can find.
Great, thanks, Melissa. Erin?
Briefly, I would just focus on a lot of what we've already talked about. I think that having confidence in yourself as a nurse and yourself as a leader, and remembering to take a step back and take care of yourself. The work will get done. I think Megan put it really beautifully. It will wait. And it will be there every single day, but it will get done. And we wouldn't be in these roles, and we wouldn't be nurses if we didn't know when we couldn't put it aside and get it done. But when you can, I think it's really important to, I very cheesily say, anyone that's ever been on a plane, put the oxygen mask on yourself first. So make sure that you're taking care of yourself as a nurse and a nurse leader so that you can take care of not only your staff, but your patients.
Great, and Megan?
One thing that's very short is, we said it before, you are always on stage. It doesn't have to be a negative thing. You can use that as a positive thing. And to always try your best to set a physical example in the way you speak, the way you dress, the way you walk onto the unit, your mannerisms, your nonverbal behavior. That is really something that if you can start off that way, if you're a new leader, people will take you seriously and will, strive to be that way too in front of their patients and their colleagues and coworkers.
Yeah, I think that's a great tip of wisdom as well. So thank you, Megan. Okay, so I would like to thank all of the panelists for their insight onto these questions and into the role. We have a few questions in the Q&A, so I'm going to move into the Q&A. Our first question is, how do you get to become an expert in your nurse manager role? It's a two-part question. And who do you reach out to for support and help? Someone in your organization or someone externally? It's not pointed at anyone, so if anyone can jump in and answer.
I can answer the second part because I am nowhere near an expert.
Go ahead, Megan.
I think that number one, my master's in nursing administration at NYU, helped me tremendously. I learned so much. Met a mentor there, our professor, and that mentorship is invaluable. Is really when you see someone that you want to emulate, you latch onto them. And it doesn't have to be every day, but you reach out to them and don't feel afraid to ask them advice and don't stay stagnant in your practice. Try to sign up for a conference that looks interesting. And of course, you're always going to be busy, but you sign up in advance and you don't know what's happening in October. And there you go, it's October and I'm really busy, but gotta go. I registered and this paid the money and or whatnot. So I think that also gives you a good breather to maybe step away from your day-to-day operations and go and network and learn about the work that other institutions are doing.
Great, thanks, Megan. Erin, do you want to pick up the first part of this question about?
I'm going to actually challenge Megan to say that I haven't met you in person, and I guarantee that you are an expert. And I hope to never have a baby in a NICU, but you seem like someone that I would want taken care of. I think that it is impossible. I mean, it's not true. I'll take it back. There are nurse managers who maybe shouldn't necessarily be in that role, but I think that for anyone who is, similar to what Natan said before, I was a med-surg nurse for a very long time. I became an assistant nurse manager in the med-surg world, and behavioral health was thrown upon me. And I went back and forth with whether or not it was something that I should do. And in hindsight, I'm so grateful And I think that through conferences and through throwing myself in, and again, like Natan said before, there's nothing that I would ask my staff to do that I'm not willing to do. I walked into the role and said to them, you know, and I don't, right? I know how to be a manager. I don't know how to be a behavioral health nurse. Teach me. And I have amazing staff members who I think are much more of an expert than I am. But at the same time, we do that together. So I think that in order to lead a unit, even somewhat successfully, that we have to give ourselves the credit for saying that we have some sort of expertise in this field, as well as in leadership, right? Because going back and putting those, that coat on every day or that hat on every day is exponentially important. And I will challenge that every single one of you is a leader.
Great, thank you both. And right, we don't always have all the answers, and sometimes, being an expert, you still don't have all the answers, but it's knowing your resources. And even if that's your staff who, take care of patients every day and they're the clinical expert, we, know to defer to them. Okay, so one more question that's in the Q&A. It says, it's wonderful to hear how dedicated to your staff you are, and I'm glad you're touching on retention of your own roles as well as clinical staff. You're often in a difficult position, and I think the role has suffered like many roles in healthcare right now. What is one thing you wish hospital leadership could implement for or would make a positive impact on your own health and well-being?
I'll jump in on this one.
Go ahead, Marissa.
I think, hearing Megan speak of the 4-day work week, and that's been, I think, in the news a lot lately, that's something that I feel would be really beneficial to at least try to implement. Throughout the pandemic, there were a few roles that could be remote, and we were there every single day. I wanted to be there every single day because I didn't want my staff going through what they were going through alone. But during that time, my director at the time implemented a triad model where we were paired with 2 other managers, and there were 3 of us. And because other areas were closed, we were able to do this, and we created our own schedule. We were there 3 days a week, but we made sure all the shifts were covered on 12-hour shifts. And the impact it had on me, my emotional health, my physical health during that time. And I know that was it was a unique time, but I think that there's things that we could learn from that in how we operate in nursing leadership going forward.
I would say I actually would credit my hospital leadership with doing a fairly good job at trying to navigate through some really challenging times. I think one thing in particular that comes top of mind is just I would love an institution as big as ours. I would love a little bit more unity between we have New York Presbyterian Hospital, which oversees, Weill Cornell Medical Center. There's a medical college, and then there's the hospital. And sometimes they work really well together, and sometimes they don't. I would love to see a little bit more unity, which now we have a new COO who's making a point of trying to focus on this, on the we, rather than on the different roles that everybody has and everybody kind of operating in a vacuum. Would love to see more unity since we are such a huge hospital system.
Great. That's a very I wouldn't have thought of that, Natan, so thanks for bringing that up. That's a good point and aspect. Okay, so in the interest of time, again, I'd like to thank all the panelists, but I'm going to hand it over back to Renee to do closing remarks for the evening.
Sorry about that. My having technical difficulties with my camera. I apologize. But oh my gosh, this was amazing. I just want to congratulate all the panelists and thank you on behalf of the Nursing Administration Alumni Advisory Council just for being here and being so vulnerable and being so transparent and honest about the crucial role that you have as nurse manager in your organization. So I can't thank you enough for being here. I thought this was an amazing event. I can speak on behalf of the council. We've been texting behind the scenes and we're just like, wow, we're so impressed. Alexa, you did a great job moderating, but I mean, honestly, just hearing the challenges and myself personally coming off of being a manager, and I did it for like 9 years and I'm a new director. I've been a director now for 1.5 years. Like, it's just going back to that manager role and thinking back to how I was and what it was like for me. And it's so true. Like, you really do have to lead by example. You have to take advantage of opportunities for growth. Also, just really learn from other leaders, whether you learn what it is to be a good leader versus what it is not to do in a leadership position. So you learn either way. You take away anything from any leader that you encounter. And just being there for your teams, I think is so important, and being transparent and real and honest and authentic and transformational. So I thank you so much for being here tonight. I think this was a really, really great discussion. And I wish you all the best in your careers. And just as a side note, we're excited to announce that our next event is going to be the Chief Nurse Executive Panel discussion, which will take place on March 23rd. It'll be in person, woohoo, on the Washington Square campus. We're really excited about that. We haven't had an in-person event in a really long time. Not only will it be a fantastic discussion, but a great opportunity to network with your colleagues. More information will be sent via email and there'll be a link to register. Thank you again for coming tonight, and we look forward to seeing you at the next event. Have a good night.